So we have cyclosporin A causing gingival enlargements in around 25% to 75% cases where you have a dosage greater than 500 mg per day. What is the mechanism of action for causing enlargement in this case? We have four options: reversibly inhibit helper T cells, proliferation of fibroblast-like cells and epithelium, increased inflammatory response to plaque, and hormonal imbalance. So what's everyone's take on it? Everyone needs to reply me to the answer they think for this question. What's the mechanism of action? See, it's an immunosuppressant. So what out of these four looks like it's going to suppress the immune response? Pretty straightforward one. Think about it. We are talking about immunosuppressants causing gingival enlargement. So they'll cause some immune response stoppage. So VJ says it's A, reversibly inhibit helper T cells. So helper T cells are a part of immune complex. They are actually. Okay, so the answer is A, that they reversibly inhibit helper T cells. The rest of the options, proliferation of fibroblast-like cells and epithelium. This is the case with what? Phenytoin-induced enlargements. Okay, we'll quickly go through the text also. See, cyclosporin mechanism of action is not very well known, but it appears to selectively and reversibly inhibit helper T cells because it's an immunosuppressant drug. Regarding other options, option B is the mechanism of action of phenytoin-induced gingival enlargement, right? Option C is the mechanism of action of enlargement associated with systemic diseases, and D is the mechanism of action of conditioned enlargement. So we talk about proliferation of fibroblasts-like cells and epithelium. This is phenytoin-induced, okay? Increased inflammatory response to plaque, that is the enlargement associated with systemic diseases, okay? And hormonal mechanism is basically the conditioned enlargement in which such a kind of response is seen. So now what is the choice of treatment? Scaling and root planing procedures, flap operation, replacing the medication, or gingivectomy? Make a guess. Bushra, you're not participating. We want you to answer as well. So we just made a new option by the name G. Okay, Vijay thinks it's D, gingivectomy. What about other people? Nikki, go for an option. Upma, you need to put in an option as well. See, you have a gingival enlargement because of a drug. Okay, will scaling and root planing help? Okay, Upma also thinks it's D, gingivectomy straight away. Bushra, can you hear us? If you can, just reply, please. We haven't got an answer from Nikki as yet. Nikki, you need to press the speech button. We're not able to hear you. Okay, sorry, Nikki, there was some problem with the voice.
Yeah, D.
D, gingivectomy.
D.
Okay, see, now let's discuss the options. Scaling and root planing in any which way is not going to help us in the reduction of the gingival enlargement because it's a drug-induced enlargement. Again, a flap operation is required where we have an osseous defect. It's a purely gingival enlargement, so a flap operation is also not a good idea. We're left with two options: replacing the medication or gingivectomy. Whenever we have a patient of a gingival enlargement because of both options of options, replacing the medication as well as doing a gingivectomy. Option A will help systemic enlargement. Yes, to an extent it will definitely help in the systemic enlargements. But of course, the main criteria being that the parameter should be kept under control. Okay. So when we're talking about drug-induced enlargement, replacing the medication will also have an effect. Secondly, doing the gingivectomy will help us restore the tissue back to its normal health. But the treatment of choice for this case would be replacing the medication, okay, because that's a much better option. Till the time you have that medication being on, once you do a gingivectomy, the relapse is going to occur, okay? And that would not be a complete treatment for the patient. A complete treatment would be to replace the medication, see how the tissue responds, and in case it's not responding, do a gingivectomy. That way you'll reduce the amount of circulating drug inside the blood, and that causes less of inflammation the next time you do a gingivectomy. You expect less of enlargement that time. Treatment of drug-induced gingival enlargement should be based on the medication being used and the clinical features of the case. As we told you, first consideration should be given to the possibility of discontinuing the drug or changing the medication. Mostly it is the change in medication and not the discontinuation, because these people are on medications which are very necessary for their survival. Simple discontinuation of the offending drug is usually not practical, but its substitution with another medication is possible. It has been shown that cyclosporin-induced gingival enlargement can spontaneously resolve if tacrolimus is substituted. Okay, so whenever you have a cyclosporin-induced enlargement, you can shift it to tacrolimus in accordance with the physician's consent as well. You have replacement drugs, as tacrolimus for cyclosporine. In case it's a phenytoin-induced gingival enlargement, you can give carbamazepine or valproic acid. In case it's a calcium channel blocker like diltiazem or verapamil can be given. See, regarding the other options, option A is the mainline treatment of inflammatory induced gingival enlargement or gingival enlargement due to enlargement associated with systemic disease. As we said that scaling and root planing, also asked by VJ whether it would be a good option to go for scaling and root planing. It is a very good option, but of course the systemic disease needs to be controlled, otherwise it will keep coming back to us. Okay. Option B is considered in larger areas of gingival enlargement where attachment loss and osseous defects are present. Of course, when you have an enlargement where you have also simultaneous attachment loss because of the superimposition of the periodontal disease, that time you do a osseous surgery in that case. Okay. Option D is valid in larger areas of gingival enlargement where sufficient keratinized tissue is present. Okay. So what was option C? Option D was gingivectomy. When you have sufficient amount of attached gingiva being present, that time it's a possibility to do gingivectomy. Otherwise, again you land up in the mucogingival line, which is not a good idea. So although option B and D both are considered in this case, but our first consideration is conservative treatment, so we will go with option C. So what are the microscopic findings in this condition? Increase in amount of connective tissue and densely arranged collagen bundles, fibrous stroma with diffusely arranged capillaries and edema, chronic inflammatory cellular infiltrate, plasma cells in the presence of an abundant amorphous extracellular substance. This is again very much histological. Go ahead and click on this. Yeah, go ahead and take a call on this.
C or D?
Chronic inflammatory cellular infiltration, or a plasma cell, and it's a plasma cells in the presence of an abundant amorphous extracellular substance. VJ says it's A or B. Have a slight towards A. Okay, what about you, Upma? Okay, yes, hi Bushra, you're back. Did you miss some of the conversation which took place? We're basically talking about gingival enlargements, and we're talking about drug-induced gingival enlargement because of cyclosporin. So the question is that what are the microscopic findings in this condition? It's an increase in amount of connective tissue and densely arranged collagen bundles, or it's fibrous stroma with diffusely arranged capillaries and edema, or it's chronic inflammatory cellular infiltrate of plasma cells in the presence of abundant amorphous external substance. The answer is D. The microscopic findings of many plasma cells in the presence of abundant amorphous extracellular substance has suggested that the enlargement is a hypersensitive response to cyclosporine. This is a very stat answer picked up from the book. Whenever you have plasma cells and you have abundant amorphous extracellular substance, that indicates toward the cyclosporin-induced enlargement. Now, which of the following statement is true? Cyclosporin-induced gingival enlargement is more vascularized than the phenytoin. Drug-induced enlargement occur in mouth with abundant plaque. Acute inflammatory gingival enlargement occurs from consistent presence of plaque. D, all the above. Take a call on this. You should have probably, kind of written down all the responses and checked how many are you getting right. VJ says it's C. Acute inflammatory gingival enlargement occurs from consistent presence of plaque. We're talking about a true statement. Any other guesses?
I think it's C.
See, if any one of these statements is false, that means D cannot be the answer, right?
Yes.
So Bushra is very true in saying that drug-induced enlargement occur in mouths with abundant plaque. It's not very necessary that you have abundant plaque. You just need a drug which can cause an enlargement. And even with minimal amounts of plaque, the response would be magnified, right? So B is a false statement. So D also goes to B, and D cannot be the answers. So we are left with A and C.
C. Acute inflammation. Which is a false? True.
Is acute inflammatory gingival enlargement consistent with presence of plaque? Think about it. Or it can be cyclosporin-induced gingival enlargement is more vascularized than the phenytoin ones. If you go back, okay, now read this up. Option B, which is proliferation of fibroblast-like cells in epithelium, okay, is associated with what? It is the mechanism of action of phenytoin-induced gingival enlargement, isn't it? We read over here that proliferation of fibroblast and epithelium is associated with phenytoin-induced gingival enlargement. Now we come back to our question. Read the A option now. Cyclosporin-induced gingival enlargement is more vascularized than the phenytoin. Busha has already made an answer of A. What do you make out of the previous statement that phenytoin-induced enlargement will be more fibrous? When it is more fibrous, that means it's less vascularized. So a cyclosporin-induced gingival enlargement is more vascularized than the phenytoin. Is a true statement in itself, isn't it? I guess A should be the answer. That's how you correlate. You know, whenever you study something, you should always correlate that what had you studied. Even if you don't know an answer to it, you can derive that answer by the knowledge you have. So in case you've gone through the previous questions well, you'll know what is the mechanism of phenytoin-induced enlargement. If you know it's more fibrous, then definitely A has to be true. Okay. So that's how you see it. Cyclosporin-induced gingival enlargement is more vascularized than the phenytoin enlargement, occurs in approximately 30% of the patients receiving the drug, is more frequent in children, and its magnitude appears to be related more to the plasma concentration to the patient's periodontal status. Gingival enlargement is greater in patients who are medicated both with cyclosporin and calcium channel blocking drugs. We'll come to that, Vijay, don't worry. So a drug-induced enlargement may occur in mouths with little or no plaque, as we said, and may be absent in mouths with abundant deposits. An acute inflammatory gingival enlargement results from bacteria being carried deep into the tissue when a foreign substance such as toothbrush, bristle, or a piece of apple core or lobster shell fragment is forced embedded into the gingiva. Right? We say that acute inflammatory gingival enlargement occurs from consistent presence of plaque. Do you get your answer, Vijay? It is not necessary that you have a presence of plaque in that area. Can be when you have bacteria being carried deep into the tissues with a foreign substance such as toothbrush bristle, piece of apple core, or lobster shell getting embedded into the gingiva. Right? Come on to case 7. This is quite a stat radiograph which lets you know which condition it is. A 15-year-old boy, quite young, reports to the clinic with chief complaint of gap between the two upper front teeth. Vijay is directly onto it. Localized juvenile periodontitis. Classical. So what's the new name for this? It was the earlier, it was called juvenile periodontitis. Now it's called local aggressive. Perfect. So now called local aggressive, earlier used to be called localized juvenile periodontitis. A 15-year-old boy reports to the clinic with chief complaint of gap between the upper two front teeth, which is pretty pathognomic because you have destruction of bone in that area. On oral examination, distal buccal migration of maxillary teeth are noticed. Of course, they will flare up. So that will be a buccal direction flare up and a distal direction flare up. So distal buccal migration. And with grade 1 mobility with respect to molars, with the kind of bone loss you have over here, of course, you'll have slight mobility also. Patient lacks clinical inflammation, which is another very good feature mentioned. Despite the presence of deep pockets, you have deep pockets, but there's no minimal inflammation. And with respect to maxillary molars as well, radiographic presentation of the mandibular molars is given. So, what is your diagnosis? Okay, pretty much straightforward. It is B, localized aggressive. Clinical features of localized aggressive periodontitis may include distolabial migration of the maxillary incisors with concomitant diastema formation. Formation increasing mobility of the first molars. Root surfaces to thermal and tactile stimuli, and deep, dull, radiating pain during mastication, probably because of irritation of the supporting structures by mobile teeth and impacted food. Periodontal abscesses may form at this stage, and regional lymph node enlargement may occur. So these are basically the clinical signs, not very relevant. Just that whatever main features we have discussed are very important. So what is pathognomic radiographic findings in this case? Horizontal bone loss of alveolar bone extending from the distal surface of the second premolar to the mesial surface of the second molar, or arc-shaped bone loss, or a vertical bone loss, or an angular bone loss. Okay, Bushra says it's B, arc-shaped bone loss. Now she's shifted to D, and VJ says it's D as well. So what's your take on this, Nikki?
Just
Only you are the
yeah,
Manmohan
suppose.
of this discussion. You take ample time to tell us what the
Mm.
answers you've chosen. But that's a good thing. You should think before speaking. Okay, you want to see the radiograph? Just a sec. We're talking about four things: horizontal, vertical, angular, or arc-shaped. Four things.
I think it's angular. Angular most probably.
Okay, VJ is
Or
asking a very good question. What is the difference between
arc.
vertical and
What
angular
is
bone loss?
hmm.
See, vertical and angular bone loss are nearly the same terms. Okay, whenever there's a vertical bone loss, it has to be an angular one and not a horizontal one. So vertical is equivalent to angular actually. So that's another indication that can those two be the answers if both of them are, concomitant, or they are similes. Can they be the answer? If one is true, the other has to be true, right? Both of them will not be the answers because only one option has to be the answer, which is, of course, it is pretty evident. It's the arc-shaped bone loss, which is also a feature of aggressive periodontitis, localized aggressive periodontitis, that you have an arc extending from the distal surface of the second premolar. Okay, that's what they've mentioned in the options. You have an arc extending from the distal of the second premolar to the mesial of the second molar. Okay, the answer is arc-shaped defect. Vertical loss of alveolar bone around the first molar incisors beginning around puberty in otherwise healthy teenagers is a classical diagnostic sign of localized aggressive periodontitis. Radiographic findings may include an arc-shaped loss of alveolar bone extending from the distal surface of the second premolar to the mesial surface of the second molar. So now what they're trying to say is that B is the answer, but it is a vertical or an angular loss. Okay. If you again go back to the radiograph, this arc is evident as a radiographic feature. Okay. When you talk about this pattern of bone loss, it is an angular defect. There's an angular defect in this area. Okay. There's an angular defect in this area as well. But the radiographic feature is an arc which is being formed. Okay. It is a vertical or an angular defect over here which is present, but the radiographic feature is described as an arc-shaped thing. So this is the arc which I've been showing over here, right? So these questions can be really confusing. As I told you, just go through, try to eliminate. Vertical, angular are the same thing. So either one of them will, if one is true, the other has to be true. So both are not the options. Horizontal is of course not the same. So B is the answer. Even if you don't know, you can eliminate and come to the answer. Okay, now association of AA or the A actinomycetum comitans with this condition is due to it stops producing leukotoxins after some time. It is the most prevalent bacterial plague. It is the most prevalent bacteria in human mouth. It produces a number of virulent factors. VJ says it's D, that it produces a lot of virulent factors. What about the rest?
Most prevalent bacteria. Association of AA with this condition is due to
I think there's some problem with the option A. It should be that it produces leukotoxins, not after some time, but it should be that ways. Anyway, I mean, that's a great hint. It is the most prevalent bacteria in plaque. Do you think AA is the most prevalent bacteria in plaque? Normally, when we talk about plaque composition, what are the main bacteria associated with initial plaque? They are the basically the aerobic rods and cocci. Then later on, the shift is there to the anaerobic bacterium. Okay, but the anaerobic ones never form the majority of the plaque component. It is the aerobic foci and rods which are forming the mass, and the topmost layers that have the anaerobic association with them. Okay, so B option is ruled out, that it is the most prevalent bacteria in plaque. Now, it is the most prevalent bacteria in human mouth. Do you think if it's not the most prevalent in plaque, will it be the most prevalent bacteria in the mouth? I don't think so. So B and C are quite well eliminated. Yes, Trump is the correct answer. So we are left with A and D. A is it will stop producing the leukotoxins after some time, and D is it produces number of virulent factors. Answer to this is D, that it produces virulent factors. A, leukotoxins are stopped. That's very true. A, actinomycetum comitans is found in higher frequency, approximately 90% in lesions characterized of LAP. Sites with evidence of disease progression often show elevated levels of AA. Many patients with clinical manifestations of LAP have significantly elevated serum antibody titers to AA, and clinical studies show a correlation between the reduction in the subgingival load of AA during treatment and a successful clinical response. See, all these features indicate that when disease is there, the bacteria is in more quantity. Whenever the disease is reduced, the bacteria reduces, right? So that means that all the relations indicate that this is associated with the disease. Also, A. actinomycetum comitans produces a number of virulence factors that may contribute to the disease process, right? So when we talk about association of AA with the condition, it is because it produces number of virulent factors. So D is the answer, and not the leukotoxin one. So let's quickly go through the factors and the significance. Leukotoxin destroys human PMNs and macrophages, whereas endotoxin activates host cells to secrete inflammatory mediators, which can be prostaglandins, IL-1B, and TNF-alpha. Sometimes this is also asked that what are the inflammatory mediators due to the endotoxin activity? These are the PGs, IL-1B, and TNF-alpha. Then there is bacteriocin, which may inhibit the growth of beneficial species. You can go through the book and just memorize these terms. Immunosuppressive factors may inhibit IgG and IgM production. And you have collagenases, which cause degradation of the collagen. Then you have chemotactic inhibition factors, which will inhibit neutrophil chemotaxis. So these are broadly the factors. And what can happen? You can have a question where 3 would be mentioned, and another factor which does not belong to this category will be mentioned. So you have to just eliminate that. For that, you should know all these factors, which are very important. Now let's come to the treatment part. What is the choice of treatment for this case? A curettage would do, or a gingivoplasty, orthodontic treatment for the diastema, or antibiotic therapy.